Good evening, sir.
Namaskaram.
Namaskar.
Am I audible, sir?
Yes,
Yeah,
sir.
yeah. Yes,
There
sir.
was some delay that invitations have not gone on time, I guess, sir. I'm very sorry for that thing.
No problem, sir. It happens.
No problem.
So I had to send again. I was informed it was sent, but then it could not. I think there was some error on our side. Very sorry for that.
No
So,
problem.
with few minutes delay, I think Rajgopal sir, Nagarajan sir, Hitesh sir, Radhavamma ma'am, and I could see other senior faculty without name like iPhone and other things have joined. Dr. Professor Saxena, we have Dr. Shubham Gupta. I could see few other faculty also. We have other two faculty who will be joining us shortly from the AIMS. I think all the AIMS have some combined meeting. So AIMS team will be joining another half an hour or so.
That Delhi chapter program is still going on.
Yes, sir. Yes, sir. I think they all promised to join little late.
I just came from there.
Oh, okay, sir. You also contributed, sir. Okay, sir. Okay.
I was an examiner for a case presentation. There
Okay,
is
sir.
one more is going on from Karnataka.
Probably, sir. Okay, sir. Okay. So, with that few words, let me ask the faculty who have joined us now to start the presentation. I also warmly welcome the students and faculty who have joined on YouTube. So, Harshal, can you, is Jain sir is joining Harshal? Harshal Tayade?
We take class ENB post-graduation.
Harshal?
National board.
Okay. Am I audible, Harshal?
Yes, sir. I can hear you. Actually,
Sir is
Jain,
joining
sir,
up.
but,
Professor Jain sir is joining.
Sir, he has said that he's coming, sir, but I don't.
Professor Lamture sir is joining. Yashwant Lamture.
Yes, sir. Sir, good evening, sir.
Oh, we are here. Sorry,
I'm available,
sir.
sir.
I didn't see. Thank you, sir. Thank you.
Good evening,
So,
sir. I'm available,
good
sir.
evening, sir. Good evening, sir. Good evening, sir. So, Harshal, you can start your PowerPoint, introduce yourself, and start your presentation. Faculty, kindly take over.
Good evening to one and all. I'm really thankful for the opportunity to be presenting on this platform, sir.
Can I please share your PowerPoint?
Yes. I'm presenting a
Go ahead.
case.
Faculty, kindly take over. Yeah, good luck.
Thank you.
Start, ma.
Starting with the history, my patient is Manikrao Ramrao Pennam. He's a 68-year-old male. He's resident of Selu, Wardha. He's a daily laborer by occupation. He's Hindu by religion. He came with chief complaints of yellowish discoloration of skin and eyes since 1 month, and multiple episodes of vomiting since 7 days, and pain in abdomen since 7 days. The patient was apparently all right 1 month back when he noticed yellowish discoloration of eyes, followed by skin, and then followed by there was blackish discoloration of urine. It was gradually progressive. It was associated with loss of appetite and loss of weight. Actually, it wasn't documented weight loss, but the patient witnessed loosening of his. The patient also generalized itching since all over his body 15 days. Patient is having multiple episodes of non-projectile, non-bilious vomiting since the past 7 days. The patient has 2 to 3 episodes daily, and they are containing food particles. Patient is also complaining of pain in abdomen, epigastric region since past 7 days. It is gradually progressive. It is continuous pain. It's constant, and it is moderate to severe in intensity. It is radiating to the back. It is aggravated at night. It is aggravated on lying down position and relieved in sitting position, and especially when he is bending forward. Negative history. The patient doesn't have any history of hematemesis or melena. No history of hematemesis or melena. No history of distension or abdomen. No history of fever. No history of cough, breathlessness, and no history of constipation and diarrhea. Past history, there is no history of similar complaints in the past, and no history of any previous hospitalization. There is no comorbidity like diabetes, hypertension, tuberculosis, or bronchial. Looking at personal history, patient takes mixed diet. He is occasional alcoholic since past 30 years. The patient has disturbed sleep due to itching and it has a particularly more disturbed since past 7 days due to severe pain in abdomen. Patient has decreased appetite and food intake. There is no history of any constipation or diarrhea. So, looking at family history, there are no history of similar complaints in the family. The patient is married since 45 years. He has 3 children, 2 males and 1 female, and none of them have any similar complaints. Looking at the summary of history, so the patient is a 68-year-old male came with progressive jaundice with pruritus, loss of appetite, weight loss, and multiple episodes of non-projectile, non-bilious vomiting, and severe pain in the epigastrium, which is more at night, aggravated on. Sorry, I'll share the screen again. I was looking at history summary. He's a 68-year-old male, came with progressive jaundice with pruritus, loss of appetite, weight loss, multiple episodes of non-projectile, non-bilious vomiting, with severe pain in abdomen, which is more at night, aggravated on lying down, relieved in sitting position, and especially bending forward, and he's occasional alcoholic. Should I move forward with examination? Looking at examination.
Hello.
Yes,
Can
sir.
you hear me? Can you hear me?
Yes, sir. Yes, sir.
Can you tell me all these episodes of severe pain, radiating, and all that thing? What do you think probably you are suspecting for that complaint?
Actually, sir, the pain that is having, it is typically radiating to back, and typically it is in lying down position and aggravated on while bending forward. It is very typical of, sir, pancreatic. Pain of acute pancreatitis, sir. Inflammation of.
Okay, just hold on. Just see, always in the examination, when a question is asked, try quickly the answer, because I have seen pain epigastrium more in the night. Everything you don't have to repeat. When I asked you the question, what you should have quickly told is probably suggestive of acute pancreatitis. Okay. Now, that is one part of it. Now, second part, you should now try to explain. Patient has a progressive jaundice pruritus with loss of appetite and weight loss. Did you mention about you mentioned black colored urine. What do you mean by black colored urine? I think I saw that.
Yes, sir. Yes, sir. Actually,
what is this black colored urine? I don't know what are you referring to?
Actually, I wanted to say that the urine is progressively turning into a darker pigmented color.
So don't get into controversy in the examination. It is not like melena. So you just tell high colored urine. That's enough. Okay?
And one more thing, you don't say that I wanted to highlight. The patient says in his own word, if he is not giving you the proper word, you try to dig out the word which is near to what the symptoms are.
Better to, yes, as Dr. Andaria sir has told, safety is more important. He may tell so many things, sir, but you should know how to interpret. You understand, no? So best is to say pruritus, correct. Progressive jaundice, very important point. And with also high colored urine, correct. Now, what about the stool? Little more description is required. What did you write about the stools?
Actually,
hello,
sir. Yes, sir. I asked him leading question, but he's not giving.
No. If it is there, you tell. I just want to know what did you ask and what is the reply. That's all I want to know. Every patient need not have every symptom. Okay. Yes.
Sir, I asked if there is any particular discoloration of stool, or if there is clay colored stool or any pale colored stool, but the patient isn't giving any.
No problem. Is there a rule that
here you mention it that there is no history of change in color of stool at least.
Yeah, you should mention, and also you should also mention any altered blood. Blood.
Yes, sir.
Is it there?
No, sir.
You should mention.
Why should you ask?
There is some noise is there, some noise. So why should you ask that history of blood or melena or altered blood or whatever it is in your patient?
Sir,
Come on, quick. You are suspecting your obstructive jaundice or not?
yes, sir.
Okay. You are
Progressive. Then
periampullary carcinoma, sir, there might be melena and
so it may be present or it need not be present. You understand, no? If it is present, it will add to your diagnosis. You understand, no? So what is
Yes,
that stools called as when the blood is mixed with the clay color? When the blood is mixed with the clay colored stools, classically it is described as aluminum paint color. Understand? Aluminum.
Yes.
That is important. Now, when this happens, what happens to the jaundice? That also you should have mentioned.
yes.
These are some important points. Please note down.
Do you get the question what sir is asking?
I couldn't hear you properly, sir.
See,
Get the question what sir is asking. Rajgopal sir is asking. Do you understand the question?
You're asking what would be the
okay, give me 1 minute time. I will tell you. When patient says my jaundice has become less and he passed altered blood or melena in the stools, what would you suspect?
Sort of waxing and waning of
Yes.
periampullary carcinoma.
So jaundice will never disappear completely, but it just becomes little better than before. Understand? So what is the difference between now? At this stage, they will ask you, what is the difference between waxing and waning and intermittent jaundice?
Sir, in waxing and waning, the jaundice will never completely disappear.
Correct. Correct.
In intermittent jaundice, it will completely go and then come back.
It may completely go. Can you give me one example for the intermittent jaundice? One example. Kya hai? Is it that difficult?
Sir, in obstructive, sir, in calculus of
so CBD. Sir, Andare sir, or anyone, please take over.
Okay, how will you ask the history of reduction in jaundice? Jaundice decreased. How will you ask that history?
Sir, I'll ask if in any change of color, sir, in, particularly in the skin, in the eye, or the sclera.
Mainly urine. That he will notice very obviously. And what type of periampullary carcinoma usually will lead to this? Ampullary growth, which may slough out and give rise to bleeding. And as it is sloughing out, the obstruction is relieved. And that's why the jaundice reduces. And this keeps on recurring if patient does not get treated in time.
Sir, infiltrating
Okay, carry on.
Sir, coming to examination, sir. Patient was examined with informed consent in a well-lit room. Patient was conscious, cooperative, and well-oriented to time, place, and person. Patient is thin built.
Dr. Harshalal?
Yes, ma'am.
What about can you describe more about you said bilious vomiting, multiple episodes. What do you mean?
Non-bilious vomiting. Ma'am, patient was having
non-bilious, multiple episodes of non-projectile, non-bilious vomiting. So can you describe it more?
Since past 3 days, patient is having actually first preceded by the patient has acute episode of pain, and then followed by pain. Mostly the patient has non-projectile, non-bilious vomiting. He has in 1 day he might be having he has particularly 2 to 3 times he is vomiting, and it contains mostly food.
What does the vomitus contain?
Ma'am, only food particles, either food particles or clear fluid.
So what do you think the reason for the non-bilious vomiting?
It can either be pancreatitis, or second it might be some gastric outlet obstruction.
Pardon?
Considering this particular symptom, two things I mean, one is pancreatitis, and the other is gastric outlet obstruction.
Why pancreatitis, non-bilious, non-projectile vomiting?
There will be obstruction of, since there is obstructive jaundice. That might
in pancreatitis, do you get an obstructive jaundice to start?
How
will the patient present to you in pancreatitis?
With epigastric pain and vomiting and
the patient will not present to you with jaundice in pancreatitis, and also no gastric outlet symptoms. Do you think so? In pancreatitis, they present with jaundice?
But ma'am, it may be associated with it because 50% of the time, gallstones might be a cause of
what? Can you be little clear about your answer?
Biliary obstruction can commonly be a cause of pancreatitis.
So you mean to say pancreatitis secondary to a biliary obstruction? What is common cause of pancreatitis? It's gallstone pancreatitis or biliary obstruction?
Gallstone.
Okay. So the pathophysiology is totally different. Okay, proceed with your examination.
Patient was examined with informed consent in a well-lit room. Patient was conscious, cooperative, well-oriented to time, place, and person. Patient was thin built.
You can go a little slow.
Patient was thin built. His height was 164 centimeter. Weight was 48 kg and a BMI of 17.5. His pulse rate was 110 beats per minute in right radial artery. Blood pressure was 130 by 80 millimeter Hg in right upper arm in supine position. His respiratory rate was 18 breaths per minute, and his peripheral SpO2 levels were 96% or room air. Patient had the icterus was present. Pallor could not be assessed because of icterus. There was no cyanosis, clubbing, or generalized edema or lymphadenopathy. As per ECOG performance score, ECOG performance.
In the presence of icterus, how do you see for anemia? In the presence of icterus, how a pallor can be assessed?
We can assess nail bed, but
nail bed is the better place to see. Okay, proceed.
It is lately little unfortunate. A postgraduate student presenting like this because of icterus, I couldn't assess the pallor.
Yeah.
It's not
good evening, sir.
Yeah, good evening. So you should have a lot
Madam,
of other
yes, madam.
for you to make a clinical diagnosis.
Good evening, sir.
Yeah, go ahead.
On per-abdomen examination, the inspection was done in supine position with leg extended and adequate exposure. The abdomen is scaphoid shaped. There is a yellowish discoloration of skin is present. Umbilicus is centrally placed, normal in position and inverted. There is no fullness or distension and no scar or dilated veins. On palpation, it was done in supine position with knees flexed. The abdomen is soft. There is no guarding.
Sorry to interfere. In the general examination, whenever the patient you are presenting with jaundice, you are supposed to highlight about the signs of liver failure. If at all, or if it is not there also as a negative point, signs of liver failure. So I'm sure you know as a postgraduate, the signs of liver failure. Can you hear me?
Yes, ma'am.
So that you should have given in the general examination before your local examination.
What are the signs of liver failure?
Ma'am, sir, spider liver, sir, gynecomastia.
The question is very specific. We are not asking the liver disease, there are other features. They're asking the liver cell failure. When the patient has gone for liver cell failure, what will be the signs you get?
Sir, ascites will be there, sir. Flapping tube,
Even
tremor.
without failure, even when the liver is not failing, you will get an ascites. Ascites is not a feature of the liver cell failure.
Flapping
Stigma
tremors.
or the signs of the liver disorder, liver disease is different. Chronic liver disorder is different from liver cell failure. So, seeing that signs, you will be predict that this patient is going for the liver cell failure. What are the first steps?
Spider nevi, sir. Flapping tremors might be there, sir.
Yeah, flapping tremor, you are right, but not spider nevi. Apart than flapping tremor, then
Sir, breath, foul smelling breath is there, sir.
why do you get that? Why do you get the foul smell? What is that smell?
It's called, sir, fetor hepaticus. It's because
What is in production in excess? And why the patient go for encephalopathy? Patient has this production, the ammonia. So all the features you must differentiate from the features of chronic liver disorders or disease and then the liver cell failure. Okay. In the general examination, I think you must be specifically mentioning all those things. This what spider nevi. How will you identify spider nevi? How will you say it is spider nevi?
there are dilated veins around the umbilicus, sir.
Spider nevi.
No.
Umbilic. Hello. Harshal.
Yes, sir.
Not.
You are talking about caput medusa?
Caput
Yeah,
medusa.
it's not. It's
But what is the difference? You are asking the spinal
not.
spider nevi.
It's in the region
Suppose
of
there is a lesion, dilated arterioles or ules, and how will you identify that this is a spider nevi? Why it is called spider nevi?
It is actually a centrally dilated, sir, a blood vessel with surrounding dilated arteriole, sir. That's why it's.
So, how will you say? How will you say it is spider nevi? What is the specificity you must demonstrate there? When you are pressing on the center, what will happen?
Sir, blanching will happen, sir, after pressure.
So, how many spider nevi is significant? Is it suppose the patient has one spider nevi or three spider nevi? Is it significant?
At least 9 to 10 spider nevi should be.
Okay.
Where is the location of spider nevi?
Sir, ma'am, actually should be upper abdomen and thorax, ma'am.
Isn't it in the region of superior vena cava, sir?
Yes, ma'am.
What is the differential diagnosis of spider nevi?
Can be seen in cirrhosis of liver in
Most common differential diagnosis of spider nevi.
Viral hepatitis.
It's mosquito
No.
bite. It's a mosquito bite. When you describe the signs of liver failure, the easier part is start from the palm and then start going up to the face and then downwards. So you'll remember all the signs of liver failure.
Exactly. You have to find a way to remember all the points, either from above, below, or from below up, or something.
From the
So that
palm,
you don't miss any
tapered
points.
on the skin, tremors, and then going upwards, loss of axillary head, the face, then go down. Then you can remember all the points. Anyways, carry on.
Oh, carry on.
on deep palpation, there was a lump of size 6 into 6 centimeter in the epigastrium. It was globular in shape. It had ill-defined margins, hard in consistency. There was tenderness present all over the rump. It was fixed. It did not move with respiration. There were non-expansile transmitted pulsations present over the one over the lump, and it became non-pulsatile in knee elbow position, and no other organomegaly was present. On external genitalia was normal, all hernial sites were normal, and there were no palpable supraclavicular lymph nodes. On digital rectal examination, there were no skin tags or mass. The anal tone was normal. Returning finger was stained with pale colored stools, and prostate was unremarkable. On percussion, resonant note was felt all over the abdomen. There was no dull note over the lump. It was all resonant. The shifting dullness was there was no shifting dullness and no fluid thrill. And
what was the percussion note over the lump? You said
resonant.
And you said hard inconsistency in palpation.
Yes, ma'am.
You mentioned as hard.
Yes.
So I mean, hard inconsistency and your resonant note don't go together. What do you try to say?
Ma'am, the lump actually is very deep. The bowel and stomach and
you are able to see the pulsation. You are able to see a transmitted pulsation over the swelling. That means the swelling is not so deep. And the patient's BMI is only 17.5. You have quoted the BMI as 17.5. That means definitely his abdomen is not going to be so
very thin individual. And what anatomical structures you expect at epigastrium?
Stomach, transverse colon.
Epigastrium.
Pylorus part of stomach, duodenum, omentum, pancreas.
You don't want to say about the left lobe of liver?
Left lobe of liver. Left lobe.
What is epigastrium? Can you explain the boundaries of the epigastrium?
The region between two mid. If we divide abdomen by passing two vertical lines from mid-clavicular region and above the transpyloric plane.
How do you know the word is transpylorus plane? You have an X-ray eye to see that pylorus plane in the surface?
Surface marking.
No, sir, from the coastal margin of the ninth rib, sir. Tip of 9.
So how much space you have in the epigastrium? You said the transverse colon will be there, stomach will be there, pancreas will be there, liver will be there. Okay. So be careful in saying what are the structures, and do not jump when your presentation already you have presented, as the madam has rightly said, it is it's a globular hard swelling, and now you are saying that percussion, it is a resonance percussion.
Can I say something, Dr. Jailal?
Yes, sir.
See, there are so many things which are somehow not matching. You know, once you said hard, then you said round, 6x6 globular. Sometimes I was taken back. Are you describing gallbladder? Because we are talking about from beginning persistent progressive jaundice, pruritus is present. You are talking about a patient with the pain radiating in the back, alcoholic chronic pancreatitis or whatever it is, doesn't matter. Then you are telling epigastrium. Then you are telling that movement with respiration issue. Figure is not there. See, all of you should try to put one small figure so that we have no idea what you are presenting, what is the location, where exactly is the mass we are feeling. So little more details expected, you know, in the exam. If you say carcinoma, how can it be round, globular, so nice swelling? So many things are a little bit, you know, worried. So I know it may be whatever you have felt. We have to worry now whether it's a pancreatic body you are talking about, or a stomach you are talking about, Or what else you are talking about in that area? Epigastrium. See, you are telling epigastrium. So better that sometimes you think twice and practice and put a diagram so that we get some idea. Thank you, Jailal. That's all.
Thank you, sir. Thank you, sir.
And doctor, you have put percussion resonant all over the abdomen. Don't say anything about that. So all over the abdomen, a resonant is not a way to tell that the abdomen. What do you try to say resonant all over abdomen? Dr. Harshad? Where is the presenter?
Actually, I wanted to say that even though the lump is there, I couldn't actually palpate dull note over the. I felt it was resonant.
But all over abdomen resonant, what do you mean by that? It's not a way to tell. Either you have to tell over the abdomen, then about the liver span, and then any other mass. And if you have an free fluid, then you can say about the shifting dullness. But all over the abdomen, a resonant note is not a way to say about the abdomen.
Absolutely, you were, as Sanai sir has said, that all the findings you need to correlate, and presentation also little more, because you are saying that auscultation also, you are saying all the quadrant, you are seeing the bowel sound. Normally we don't see in all the four quadrants. Certain things definitely needs to improve, because see, one of the advantage of this PG clinic is all these lecture classes are available on the YouTube. So
Yes.
you can just have a look on through what was the mistakes pointed out and what are how to improve. Yes, it is, though it is a teaching session, but again repeatedly we are talking about the basics, then other students may not get interest. So it is better, all of you, the students who are practicing, please refer back to the YouTubes. All these cases here multiple times these are discussed.
Exactly.
And at least you should be justifying whatever you say. There should not be any haphazard history, haphazard examination finding that there is no correlation whatsoever. At one moment, you are thinking of gastric outlet obstruction, at one moment pancreatitis, at one moment obstructive jaundice with mass, hard mass. So they don't come anywhere nearby. Your diagnosis or history examination findings should be such that you can think of 1 or 2 or 3 diagnoses which have common symptoms and examination finding, not very extreme and 180-degree findings.
Exactly, sir.
Marshall, if you are given a choice to put your stethoscope at one place in the abdomen to auscultate the bowel sound, where you will put your stethoscope?
In the right iliac fossa.
Right iliac fossa.
Right iliac fossa?
Right lower quadrant. Right lower.
You will put it in the right paraumbilical region, okay?
Right paraumbilical.
Yeah, that is if you have to just put your stethoscope at one place only. Noted, how do you know this is a non-expansile transmitted person, you said?
I palpated the swelling, the lump with 2 fingers, and since if it was an expansile swelling, the fingers would diverge when the pulsations are there. This is one method, and second is when the patient is taking knee elbow position. Sir, then the pulsations ceased. The swelling was no more pulsatile. So that tells me that it's not an expansile swelling, but actually a transmitted pulsation, sir.
So in the abdominal lump, you do it by the 2-finger test to check for whether it is a transmitted or expansile pulsation.
Actually,
the abdominal lump. If it is over the extremity is there, like it is over the radial artery or brachial artery is there, then it is okay. That you can do the 2-finger test there, but not on the abdomen. The only way to tell is that either you make the patient in the lateral position or in the knee elbow position. Lateral position is comfortable for the patient. The knee elbow is little uncomfortable. So if you make the patient in the lateral position, if the pulsations they disappear, then it is a transmitted possession. But if it is still present, then it is the expansile possession. Okay.
The
Right.
normal bowel sound you have heard in all the 4 quadrants. What was the normal bowel sound here? How many sounds you heard per minute?
5 to 30 bowel sounds per minute are considered normal.
30 bowel sound is the normal.
5 to 30.
It's a wide range.
So either you have to change your stethoscope or you have to check the ENT opinion. Get the ENT opinion. So this is a basic. I mean, also you must learn at every patient. Please try to put your bowel sound in stethoscope and see for the bowel sound. It is the sweetest music to the surgeon. And you can't make a mistake on the bowel sounds. Go ahead. And rectal examination comes after you are completing your examination. Look, it is not after the before percussion and auscultation.
Sorry. On systemic examination, S1 S2 are heard. The higher functions were intact on CNS examination, and bilateral aridity was present. There were no added sounds on respiratory system examination. Summary: the patient is a 68
There is
or
no sensory and motor deficit. Then why you put the patient under ECOG 3? You have put the patient in the general examination. You said the patient is on the ECOG 3.
Yes,
What
sir.
do you mean by that?
Sir, the patient is unable to perform all his. I mean, he requires help in all his routine self care, sir. That's why, sir, I put him in ECG.
So how will be all his motor and everything will be normal? In a general examination, one side you are saying patient is on a ECOG 3. Then you are saying his every function is normal. Absolutely is normal. Try to correlate all the findings and try to say only what you are seeing exactly you have to say. Don't change on those things. Go ahead.
So summary, sir, patient is a 68-year-old male with progressive jaundice associated with pruritus, weight loss, and loss of appetite since 1 month. Since past 7 days, patient is having multiple episodes of non-projectile, non-bilious vomiting with severe pain in epigastrium, which is more at night, aggravated on lying down and relieved in sitting position. Patient is occasional alcoholic. The ECG score is 3. Patient on examination, patient is icteric. Patient has tachycardia. There is 6 into 6 centimeter size, well-defined, hard, fixed, tender pulsatile mass present in the epigastrium.
Arshal, at any time, a epigastric mass will have all the borders filled. Can you feel all the borders to say it is 6 into 6 well-defined in all margins? Is it possible with an epigastric mass?
No, it's no.
In case of obstructive jaundice, what will be the pulse rate you are expecting normally?
And why?
Suppose you have obstructive jaundice. That what is the effect of that on the heart?
If you don't know, say don't know, sir. So we can continue, beta.
Sir, I don't know, sir.
So it will have an inhibitory effect on the synovial node. So patient will have a bradycardia. So here in this patient, you are expecting tachycardia. So this when we
See,
case,
yeah. Just since Madam also raised that question, you think it's only in the epigastrium, or if you draw the quadrant properly, or is it going in from epigastrium to the umbilical region?
Yes, sir,
That's one thing. You said hard fixed pulsatile. Upper
And
border
tender. And you said tender.
Tender. Upper border could be made out. Hello. Hello.
Yes, sir, I can hear you.
Hello. You can get the upper border very well, correct? Am I audible or?
I can hear you, sir. Yes, sir.
You can
according what
answer that. You can answer whether it is correct or wrong. You can just say so that we know that you have reached the.
Yes, yes. Because the whole idea is, see, when you give a diagnosis, you should be convinced. Is it a epigastric mass stomach we are talking, or is it a pancreatic mass we are talking, body? You are telling pulsatile mass, hard mass, fixed mass. So we want to have some clarification. That is why you have to be very clear.
Harshal, hello.
Yes, sir.
Harshal, whether this mass is above the transpyloric plane or below the transpyloric plane, or it is present both on above as well as below the transpyloric plane.
Actually,
What do you think?
most of the mass was above the transpyloric plane, but sir, the lower border it was just touching the.
But some part is in below the transpyloric plane also, I think. Isn't
Sir,
it?
The lower border, yes, sir. It was,
So that means it is extending into umbilicus.
yes.
Okay.
Yes, sir. Yes.
So
That is the point I wanted to make.
hello.
Yes, sir. I can hear you.
Yeah. Sir is also asking about the same thing, so that you can explain the origin of the mass, isn't it? Otherwise, it is not possible to explain the origin. You are telling that the mass is present in only epigastrium. Okay, continue.
So most of it was in epigastric region. That's why I.
Okay, no issue. Continue.
What is your diagnosis? And then we'll talk about the probably prognosis and proceed.
Sir, my provisional diagnosis is acute pancreatitis with biliary obstruction due to malignant pancreatic mass.
Why do you think of acute pancreatitis here?
Hello. Actually, patient is giving characteristic history of pain, which is very typical of pancreatitis.
Malignant pancreatic tumor, whether it is a painful or painless condition.
Usually, sir, in pancreatic tumor, it is painless, or there might be mild dull-aching pains, but mostly it is
not a mild pain. Pancreatic pain is always severe pain. So why do you get the pain in pancreatitis, in pancreatic tumor?
Sir, due to inflammation and
whether it is the inflammation or infiltration.
Any malignancy, when does it give rise to pain?
Sir,
whether it is the infiltration of surrounding nerves or inflammation.
Sir,
always due to the infiltration. So like inflammation will not. Just because there is a pain, it is not justifiable to put the diagnosis of acute pancreatitis. When the patient is already presenting with a severe jaundice and you are able to make out a mass, a huge mass, what do you think in terms of an acute pancreatitis condition there?
Is it common to have acute pancreatitis?
Exactly. It does not come in differential diagnosis at all. These two diagnoses do not come at all in the differential diagnosis.
Differential diagnosis. Not
and by and large, for clinical presentations, forget acute pancreatitis in your exam. So never think of it. Right? If
you will not keep that for examination.
Sir, what did you say?
When the patient is in acute pancreatic pain, it will not be kept for your examination.
Exam also.
It will be in casualty, emergency room or ICU.
He will not be kept in the exam.
Exactly. Second thing, either this is a very different case, or there is some mistake, or there is some hypothecation. This is what I presume. I may be wrong.
Okay, sir, can I say something, sir?
Yes, sir. Yes, sir.
I just want to go a little to the side of my candidate and I will ask him, if you
Yes, sir.
think acute pancreatitis, fine, what is the complication of a pancreatitis can present as a large epigastric mass.
Yes, sir.
Tensely cystic mass you would have felt as hard, you would have felt, and rounder and pulsations present. Can you give me the tender? You use the word tender.
Tender, yes.
Now I am on your side as examiner. Can you now tell me the diagnosis?
Pseudocyst of
So what I'm trying to tell is you need to talk. See, postgraduate level, everything depends upon how you interpret, how you talk. Your findings should mostly match your clinical signs, symptoms, and the findings. Even though less likely, but sir, there is a large pseudocyst. Maybe a patient is having chronic pancreatitis because you started from beginning pain radiating to the back, etc., etc. With a large mass there, two possibilities I will consider, sir. One is yes, tenderness is, if you believe in your tenderness, whether it can be a tense pseudocyst, and patient has got a tachycardia, no? Pulse rate 102, correct?
110.
If I am not wrong. So you also should make a mention about that when you write whether patient is in cholangitis or not. Okay. Okay, sir, just I took his side, sir.
Yeah.
Yes. You must justify whatever you say. If at all, you stick to it.
How do you explain the jaundice?
Exactly, that's what I was thinking.
Ma'am, if it is a pancreatic mass, and it will be obstructive.
No, your diagnosis of acute pancreatitis with a pseudocyst, how do you justify for the progressive jaundice?
Due to gallstones.
Gallstones. Gallstones never produce jaundice.
Putting into more trouble by giving the pseudocyst into him.
Or might be, ma'am, compression of the biliary tract due to the pseudocyst, due to the large pseudocyst. And
pseudocyst goes and compresses the biliary system. Okay, anyway, in the exam, kindly don't say acute pancreatitis in a malignant situation, which will drag you into trouble. Remember that and don't do that in the exam.
One more thing to remember is logic. Most of the examiners have asked the questions from whatever you have said. The questions are not fitted in our mind, or they are not a set of questions for a particular case. So whatever you say, Dr. Harshal, you must be able to think logically. Then if you know the answer of that sentence, what question can be arised, what can be answered. If you would have thought it logically, probably you would have not kept. I am not criticizing you. Don't take me other way around. But whatever you say, you must be able to justify. The investigations finding maybe whatsoever 180 degree than whatever we think logically. You must apply logic, your clinical experience, whatever you have seen in 1 or 2 or 3 years, and whatever is given in standard textbooks. Then this situation will not arise.
They should correlate, no, sir. That's also important. No,
yes,
sir.
Correlation and logic is very important. History, examination, finding, everything.
Dr. Harsh, you will not be given any investigations in the exam. It is only with the mere history and your examination, and as sir said, the logic behind it, that the diagnosis will be arrived. Maybe right, maybe wrong, but that is the way a diagnosis will be arrived.
Your approach is what we are assessing, and not your diagnosis.
Exactly.
I'll give you one example. Recently, I had been to one UG exam, and every student used to say that patient says that there is rupture of vein. Patient was from different state than our Gujarat, and he used to say that na se phat gayi. What he wanted to say was that there are dilatations of lower limb vein. Patient had varicose vein, but the UG students literally they took the words which he said. He was from Rajasthan, that the veins got torn. So this is not the way. You have to justify and use the proper word of a local language, layman's language, and then we have to come to the history presentation. Don't get disappointed. It happens. This is the best way of learning. You can try to improve. What I'll suggest is you read, exercise all the things and present to your local faculty. You can definitely improve.
Any relation to the Corvosius law in this case?
No, sir, because no palpable gallbladder mass, sir.
Why? How do you explain?
Normally, sir,
There is a chronic.
Normally in CA pancreas, there is distension of gallbladder, and that is what Corvosius law states, that which is why gallbladder becomes palpable. But in this case, it was not palpable, sir.
Exception? Is it an exception, or it is not? The diagnosis is not correct.
Pancreatic mass, will it be? Is it an exception? So this is another analogy we are seeing. The case you are having jaundice, but you are saying there is no other mass is palpable, or maybe you are right, because it is not always it is true that the gallbladder should be dilated.
One thing comes to my mind is there is a patient who is an alcoholic. Patient presents to you with gastric outlet obstruction like symptoms. There is a mass, and there are signs of double duct and all in CT scan. This may be the case. In that case, what should be the diagnosis if you know theory? Patient with probable signs of double duct sign, maybe jaundice, and features of gastric outlet obstruction, who is an alcoholic male. What is the diagnosis? Which is not a common diagnosis. That can be the case. This is what I am thinking now. Do you know what is groove pancreatitis or paraduodenal pancreatitis? In that case, patient has gastric outlet obstruction. The duodenal mucosa is thickened, and patient does have obstructive jaundice. Patient may present with acute exacerbation of acute pancreatitis. There may be dilated pancreatic duct, and this is the only case where a Whipple's procedure may be indicated if it is irreversible and for a benign condition. Groove pancreatitis. Have you heard the name?
Yes.
Okay. This is what I am thinking, that if this is the real case, it can be a case of groove pancreatitis, where you may feel a lumpish feel, but usually it won't be hard.
How you are going to proceed?
Actually, sir, considering I thought that it might be acute pancreatitis, so I decided to proceed with all routine investigations with CBC, with amylase lipase, with blood KFT, LFT, CA 19.9, CEA, and
Objective is get the diagnosis. All these will be to help you later when you are going to plan the treatment modalities. So CBC and other things you are not going to give you a diagnosis on that.
So we'll go for. I'll like to go forward with the contrast enhanced CT scan to confirm.
What phases you will take for pancreas? What phases you will request the radiologist?
No pancreatic protocol CT.
Sir, triple phase, sir, CT. Sir, arterial phase, venous phase, and delayed phase.
Washed out phase. Okay. So what do you think the picture will be CT in this diagnosis? With your diagnosis? CT picture for this your provisional diagnosis?
I'm expecting mass lesion, ma'am, in the head of pancreas, or and along with there might be dilated, ma'am, CBD and the biliary tree. Peripancreatic. There will be fluid collection in the peripancreatic space also.
What is that mass you felt? Where do you think it will be?
Ma'am, in the retroperitoneal area near the should be adjacent to the aorta, abdominal aorta.
Mass is arising from pancreas or not?
But, I think it is arising from pancreas.
Oh, you finding CT. You have done a CT, no? You have the CT report.
No, sir, not right now. I left. CT for this patient is CT has been done.
CT not done?
CT done, sir, ma'am, for this patient.
What was the finding?
They have given pancreatic mass in the head of pancreas. The size they have mentioned was 6 into 7 into 5 centimeters. And along with that, there was distension of gallbladder and dilated biliary tree.
So there was no features of acute pancreatitis.
There were features and that mentioned so they had given the report with biliary obstruction with distended gallbladder with pancreatic mass and with acute pancreatitis.
I think the problem is of CT scan report, isn't it? So you don't correlate your history examination finding to whatever the reports or diagnosis are. That is the bottom line.
Can I well, sir, has given a message. It has to finish.
Yes, sir. Yes, sir.
And most of the times it's only an image. You are seeing the real. And you want to believe the image and shift your diagnosis accordingly, you will mostly go wrong.
Very true, madam.
What is the double duct sign? What is double duct sign?
It is seen in periampullary carcinoma, sir, on
What is that sign? What are the things you see?
Sir, actually the pancreatic duct and the common bile duct, sir, both of them they appear dilated because of obstruction by the periampullary mass.
What is the diameter of the pancreatic duct?
Normal diameter.
5 to 6 mm, sir.
5 to 6 is dilated, isn't it? What is the diameter of the CBD?
Sir, 2 to 4 millimeters.
You mean the pancreatic duct is more dilated than the CBD?
So for pancreatic duct, it should be 1 to 3 millimeters.
Up to 3 millimeters. No? Pancreatic and the bile duct is 5 to 6 millimeters. So in an elderly male patient, if you find that the patient has a double duct sign, it is diagnostic of?
Periampullary carcinoma.
In a young patient, you find the double duct sign. What does that indicate? If in a young patient, you find a double duct sign. Probably calculus impacted at the ampulla of the water. Okay. So, in the elderly male patient, it is almost diagnostic of the lower end of the either cholangiocarcinoma or the periampullary carcinoma, you can say. Okay. So in this patient, what is your plan now? What are you going to do for this patient?
thing was to stabilize the patient, sir, with right tube, 2 wide bore cannulas and Pullis catheter. I'll start IV fluids and after that we'll have to do biliary drainage, sir.
What are the various ways of doing the biliary drainage?
Sir, external and internal. So the most preferred way would be endoscopic by the endoscopic route, sir. But sir, we can do endoscopic cholecystography. It's both diagnostic and therapeutic, and along with that, we can do the biliary stenting, sir.
What is the role of endo ultrasound in the biliary drainage?
It has both.
You know what is endo ultrasound?
Yes, sir. Endoscopic ultrasound.
Yes. So what is the role of endo ultrasound in the biliary drainage? Like we are not able to do the ERCP drainage, you are not able to go through the lower end. Can you have the help of the endo ultrasound in biliary drainage? So it will help you, it will guide you. You can put a stent. If you are not able to go through the ERCP, through the ampulla, you are not able to go, then you can go directly to the bile duct with the help of the endo ultrasound. So there is a distal obstruction, but the proximal is widened or it is dilated. You can do a drainage of that with the help of the endo ultrasound. Why you want to palliate the jaundice? What is the most important reason to palliate a jaundice?
Sir, patient will go into cholangitis, biliary sepsis, and deteriorate. That he'll go.
Dreaded complication of jaundice? Dreadful complication of jaundice, progressive jaundice.
Sepsis and encephalopathy, septic
encephalopathy.
How does it affect the quality of the life? Even if the patient is not having very severe jaundice, the patient is not going to encephalopathy and all those things. How it is?
Sir, patient will going to have pruritus.
Yes, pruritus is the most important thing.
Yes, sir.
Okay, that really makes the quality of the life very worse. Okay, so one of the very important reasons for palliation the jaundice is to get relief from the pruritus. Okay. Can we stop it?
In the exam, whenever a case is given like that, with you suspect as a epigastric mass with jaundice, try to avoid an inflammatory and a neoplasm combined. Avoid that in the exam. Never combine an inflammatory process and a malignant process together.
I remember that, ma'am. I'll remember.
Yeah.
Thank you, ma'am.
Dr. Kanagavel, sir.
Dr. Kanagal, can we stop it here or we should go?
Yeah,
Yes, sir. Yes, sir.
we can move on to the next, no, sir?
Yes, madam. We have Janani already joined up.
Yeah.
Arshal, do you have any questions, Arshal?
No, sir. I'm thankful. I'll remember all the points, sir. For my
Thank you very much, Arshal.
Don't get upset that we interfered and asked many questions. This is the way you can improve. This is the student period that you can listen to the expertise comments and get improved yourself. Thank you.
Thank you, ma'am. Thank you, sir.
Can you unshare your screen?
Yes,
Arshal, you unshare. In the meantime, I just want to tell you, in a patient wants to decide obstructive jaundice based on your clinical findings. First, clinical findings means history, itching is there, progressive jaundice. Immediately, you should start thinking in the mind 1 or 2, 3 common things. Always common things are common.
Exactly.
Uncommon things are uncommon and rare things are rare. First thing you think like that. Now, having said that, yes, periampullary carcinoma, head of the pancreas will come into your mind first for this age group with loss of weight, appetite. Then, of course, stone, choledocholithiasis. These two things to be kept in mind. Endemic zones where there is a chronic pancreatitis, which is also a pre-malignant condition. It can give rise to a head mass also. After doing that, doing the general examination, then clinical findings, you have to really check properly and pictures to be drawn and answer to yourself whether this will match with your findings. So logic important, correlation is important, interpretation is important, and then one or two differential diagnosis. I think that's all. I'll stop this level. Thank you.
I'll add to Rajgopal sir's sentence.
Yes.
There is a
Yes.
dictum that if you diagnose rare disease, you are rarely correct.
Correct.
Exactly.
Sir. So Prakash sir, welcome sir. Thank you for joining us.
Thank you, sir.
Janani, you can unmute yourself, start sharing your screen. Please make it full screen, Kana.
Yes, sir.
Good luck, Janani.
Thank you, sir. Good evening, everyone. I am Janani, final year postgraduate from PSG Hospitals, Coimbatore. I'm doing my PG under Surgery 4 unit, Dr. Prem Kumar sir, and our HOD is Dr. Rajesh Kumar sir. And special thanks to Dr. Sharada ma'am, Chairman ASI Coimbatore, for giving me this opportunity to present in this forum.
Good luck. Carry on.
I'm presenting a 65-year-aged gentleman coming from Tirupur, a retired clerk, who is a lower middle class, hailing from a lower middle class family. Came with the chief complaints of history of yellowish discoloration of eyes and urine for past 1 month. History of presenting illness. Patient was apparently normal 1 month back, following which the patient developed yellowish discoloration of urine, which was insidious in onset, intermittent in nature, noted by himself. History of severe itching all over the body, more during the night time, which now reduced in severity for the past 1 week. Patient has history of passing clay-colored stool for the past 1 month intermittently, with a few days passing yellow-colored stools on and off. The exact duration and the duration of the stools, discoloration of the stools is unknown to the patient. And the history of melena for the 2 days in the past 1 week, 1 week back. History of fever, 1 episode 1 week back was present, which is low grade and not associated with chills and rigors. The history of loss of appetite was present. History of loss of weight of 8 kgs in last 1 month is present. No history of abdomen pain. No history of abdominal pain radiating to back. No history of postprandial fullness. No history of constipation, loose stools or steatorrhea. No history of vomiting or hematemesis. No history of bleeding from gums or easy bruising. No history of cough with hemoptysis. No history of dyspnea. No history of abdomen distension. No history of diplopia or seizures. No history of backache or any bone pain. Past history, patient is a known case of type 2 diabetes mellitus since 2004. He is on regular treatment with oral hypoglycemic drugs. He is not a known case of hypertension, coronary artery disease, bronchial asthma, or tuberculosis. History of native treatment for 2 weeks for the treatment of jaundice 20 days back was present in the form of oral medications. No history of surgery, any surgery in the past. History of pleural trapping present 30 years back. He was diagnosed to have pneumonia. No history of blood transfusion or chronic drug intake. No history of previous similar history of jaundice. Personal history, patient consumes mixed diet, has normal bladder and bowel habit except for the discoloration. He's a chronic smoker for the past 40 years and 40 pack years. He's not an alcoholic. Family history, there is no history of any other malignancy running in the family members. No history of jaundice in family members. Shall I summarize, sir?
Yeah.
Presenting a 65-year-aged gentleman who is a known case of type 2 diabetes mellitus, a chronic smoker, came with the complaints of intermittent painless, yellowish discoloration of urine and sclera with passing clay-colored stools and occasional melena. Patient has a loss of appetite with significant loss of weight, with no significant family history.
So, at the end of your history taking, what do you think you are dealing a case of?
My working diagnosis is intermittent painless obstructive jaundice, mostly malignant. Since the history of melena is present, I would like to I may proceed with I may tell this is a case of periampullary carcinoma.
So probably.
Probably.
Okay.
Do you understand what is the difference between an intermittent jaundice and waxing waning jaundice?
Sir, in intermittent jaundice, the jaundice comes to the baseline, and then waxing and waning, that is a fluctuating jaundice, the jaundice does not touches the baseline.
You are making a diagnosis of periampullary carcinoma and you are saying the patient has an intermittent jaundice.
Yes,
are you
sir.
justified with that?
Sir, since in periampullary carcinoma, the patient, the mass will, the necrosis will happen and the mass slough out, and the obstruction is partially relieved. And in that case, it is a waxing and waning type of jaundice is present, sir.
Rather than intermittent.
That's what I am asking.
Yeah.
Yes.
Is it a case of waxing waning jaundice or it's a case of intermittent jaundice?
It's a waxing and waning type of jaundice.
So it is not intermittent, is it?
Not intermittent.
Can you
And
narrow
you say
down
there
the
is only.
diagnosis? Sorry, sir. Sorry.
No, please continue, Dr.
Carry on, sir. Carry on, Kanasta.
No, just asking, this patient only had a discoloration, the urine only, not the eyes?
Eyes also.
So eyes also, sir.
Have you written this somewhere?
Yeah.
But in the summary, you are saying it is only discussion of the urine only.
Sir, as a yellowish discoloration of urine and the eyes, so I mentioned.
Okay, so now tell me, what is the cause of the way the discolored urine is there, but the eyes are not yellow? Urine is yellow, but eyes are not yellow.
Sir, in case of dehydration, patient may have yellowish urine with eyes not
high color.
High colored urine.
Any other
medications like B complex, vitamin B complex can cause yellowish discoloration of urine with absence of yellowish discoloration of sclera.
Good.
Now tell the eyes are yellow, but urine is not yellow.
Sir, in case of hemolytic jaundice, patient will have an acaloric urine, and also in case of blood transfusion, if any reactions, patient may have a hemolytic jaundice.
That is also hemolysis, na? So in the case of hemolytic jaundice.
Hemolytic jaundice.
What is the cause of yellow color of the urine in jaundice patient? Why it is yellow?
Sir, because of the presence, excess secretion of the conjugated bilirubin, in the urobilinogen is absent, and the bilirubin is excessively secreted in the urine. Because of that,
urinary urobilinogen.
So it is because of the. Can you again confirm that why it is yellow?
Bilirubin will be there.
Urobilinogen is present.
It is because the conjugated bilirubin.
Bilirubin is present.
So it is because the conjugated bilirubin. Nothing to do with the urobilinogen. Urobilinogen is absent in case of the
Absence in obstructive jaundice. Yes.
You were said as a clay colored stool.
Yes,
what
sir.
do you mean by that?
Sir, it's a pale colored stool, sir, in the absence of the bile pigments in the
pale colored stool, or the recent change in the original color, because clay, it is our Indian clay is not that.
The China clay is the clay which look like pale colored.
India, no, we are talking so better to use the term pale color.
Okay.
You said it's progressive jaundice, and how do you decide that it's a progressive jaundice? We are only in the history. How do you say it is a jaundice?
Sir, it is a vaccine and banning type of jaundice, sir. So I cannot get the question, sir.
No, so in beginning, I thought you said that progressive deepening of the jaundice is there in this case.
Okay. So patient has intermittent passing, the the color of the urine is intermittent, yellowish discoloration, and he passes normal colored urine, and the clay colored stools also he passes yellow colored stools in between. So it is a vaccine and waning. So patient has itching in the first 2 weeks of the starting, then it decreased.
What is the reason for itching?
So the itching is due to the deposition of bile, which causes the irritation of the nerve endings and causes itching.
Explain what is that bile? What? Bile
So
salts, bile pigment.
So the bile
pigment or bile salts?
So bile salt.
Bile salts.
So you must be very careful on that. No? It's not the bile pigment, it is the bile salts. How will it test for the bile salts? How will you check for the bile pigments? The urine, how do you asking for that? What test they will do?
Sir, urine urobilinogen and bile salts we can check in urine complete.
No, what is the test?
Sir, colic and deoxycholic salts present.
Base test. The basics of the basic examination, all the steps you must know. How do you check for the bile salts? How do you check for the bile pigment? And what is the importance of checking the bile salts and bile pigments? And even if we are sending the urine, how quickly it will be tested? All these basics. Okay. You had the patient had a chronic smoker.
Yes, sir.
So anything significant in the patient with the chronic smoking having a jaundice, and any possibility you think is any predisposing factor?
Sir, the chronic smoking has a 40% risk increased chance of getting pancreatic malignancy, and
more in favor of a pancreatic malignancy.
Pancreatic malignancy.
Okay, go ahead.
On general examination, after obtaining consent from the patient is exposed from nipple to mid-thigh and examined under good natural light. Patient is conscious, oriented, moderately built and nourished, well hydrated. The BMI is 24, ECOG score is 1. Icterus present in the sclera and bulbar conjunctiva. No pallor, icterus, cyanosis, clubbing, pedal edema or generalized lymphadenopathy. The scratch marks present all over the body. There is no signs of liver cell failure. On vital examination, patient is afebrile. Blood pressure is 130 by 80 millimeter of mercury. Pulse rate is 64 per minute, regular rate and rhythm. The saturation is 98% in room air. On inspection, the abdomen is distended, umbilicus is centrally placed, inverted. All quadrants move equally with the respiration. There is no visible mass. The skin is abnormal. No scars, sinuses, or no caput medusae. No engorged veins. No visible pulsations. No visible peristalsis. Hernial orifices. No cough impulse. On palpation, the abdomen is soft, non-tender. No local rise of warmth or temperature. The liver is palpable 2 centimeter at the mid-clavicular line below the right subcostal margin. The surface is smooth, borders are rounded and firm in consistency. A 5 cross 3 centimeter pear-shaped, non-tender palpable mass just below the right subcostal margin, medially 7 centimeter lateral to the midline, laterally just lateral to the mid-clavicular line, inferiorly extending into the just at the right lumbar region, with smooth surface, firm in consistency, well-defined lateral, medial and the inferior margins. The superior margin is continuous with the liver border. Side-to-side mobility is present, and the mass moves with the respiration. On no other palpable mass, other findings of the inspection confirmed. The external genitalia examination is normal. Both testes is normal. On percussion, the upper border of the liver dullness in fifth intercostal space in the mid-clavicular line with a liver span is 15 centimeter. Percussion over the gallbladder is continuous with the liver dullness. The shifting dullness is present. On auscultation, bowel sounds is normal. The perirectal examination, there's no skin tags, no fissure or sphincter tone is normal, no palpable mucosal lesion or deposits. Stool staining is pale colored, no melena. Left supraclavicular region examination, no palpable lymph nodes. Other system examination, respiratory system, breathing is abdominothoracic, bilateral air entry is equal and adequate in all zones, normal vesicular breath sounds with no added sounds. Spine and cranium is normal, no paraspinal tenderness. Cardiovascular system, first and second heart sounds is heard, no murmurs. Central nervous system, normal, no focal neurological deficit. My provisional diagnosis is a malignant obstructive jaundice, probably due to periampullary carcinoma.
In your case, pulse rate is 68 per minute.
Yes, sir.
How do you explain that?
Sir, in obstructive jaundice, the bile salts deposition at the SA node will cause bradycardia, and also in obstructive jaundice there is a myocardial suppression factor which is released, and because of that there is a bradycardia in obstructive jaundice.
What are the other reasons apart from these two reasons? It can get deposited over the AV nodes also.
AV nodes also. Okay, sir.
And it can irritate the vagus also. There's a vagotonic effect is there.
Yes, sir.
Okay, so these are the various factors for the relative bradycardia in the patient with the obstructive jaundice. Now you said the liver span is 15 centimeter in the mid-clavicular line. But in the mid-clavicular line, you have a gallbladder lump there. So how could you appreciate that liver span in the mid-clavicular line in this patient?
Sir, in correlating with the later borders of the liver, I just made it.
So if you find that there is a lump at the mid-clavicular line,
yes, sir.
then you have to move to some other place.
Okay, sir.
Okay, you may go to the anterior axillary line, or you may go toward the epigastric region. You know what is the liver span in the anterior axillary line? How much is the normal liver span?
So 12 to 12.
It's about 12 to 14 centimeters.
12 to 14 centimeters.
In the mid-clavicular line, it is 9 to 11 centimeters, while in the anterior axillary line, it is 12 to 14 centimeters. So you can move there, if you want, if there's a lump which is there in the mid-clavicular line.
Okay, sir.
Okay. Yeah.
Question, you said you are looking for some dilated veins, and look for dilated veins in this case.
So since since the abdomen is mildly distended and there is a shifting dullness, and also I suspect other features of liver cell failure may be present. So I looked for dilated veins.
Where do you look for dilated veins in the liver cell failure?
Sir, in case of a SVC obstruction, the dilated veins are present over the and.
Dilated veins present over the?
Sorry.
Why it produces SVC obstruction?
Sir.
So in the inspection, you said there is no dilated veins and no caput
No
medusae that you are. Caput medusae, I understand. But what dilated veins you look for?
Sir, in the flanks, in the distended abdomen, usually dilated veins will be present, sir. That is all.
What does it indicate?
Sir,
if there is a dilated vein in the flank, what does it indicate?
Sir,
it's
a moderate ascites.
Ascites will not produce dilated veins. Ascites obstruction to the IVC. Then
IVC.
you will have a bilateral. If it is obstruction to the common ilia, one side, you will have one side. Suppose the blood is obstructed at the IVC, how the blood goes to the heart?
So to the
What is the alternative pathway from the IVC? One is now this lateral vein. What's the main?
If the IVC is obstructed, it goes through the
It's Asega system. So Asega system of veins, it's only communicating between the SVC
and
the
the IVC.
transverse bypassing wherever it is, because it's Asegas STC all the way. So how the Asegas is formed? Asegas vein is formed?
Sir,
Superior lumbar and the subcostal vein to form the Asegas, and all the intercostal veins joins the rest. Okay, go ahead.
Okay, sir.
How will you differentiate whether it is the veins which are there on the abdominal wall because of the portal obstruction or because of IVC obstruction?
Sir, on the milking the
Milking or flow?
Sir, after occluding, we have to release and see whether it is filling from above or above downwards.
What is the direction of the flow if it is the IVC obstruction?
Sir, in IVC obstruction, it is it is above downwards.
The other way around. It goes from below up, you know?
Below down, below upwards. Okay.
Below. And in the case of the portal obstruction,
it is above downwards.
Remember, as
it is away from the umbilicus.
Okay,
it radiates away from the umbilicus.
Okay, sir.
So in the upper part, it may be in the other direction, while in the lower part, it may be different direction. So whenever you have to check whether it is the flow of the blood is because of IVC or because of the portal, you always examine below the umbilicus.
Okay, sir.
Never above the umbilicus. Above the umbilicus, the direction will be the same.
Okay,
while below the umbilicus, it will be different.
Okay.
That is one way of the knowing about that. And then you look at the back of the patient. What you will find in the back of the patient? Find the prominent veins in the back of the patient.
Okay,
then that
sir.
is suggestive more of a IVC obstruction.
Okay, sir.
Okay. It is not there in the portal obstruction. So that is the way you can differentiate whether it is a because of that.
Okay, sir.
So you have written the diagnosis malignant obstructive jaundice.
Yes, sir.
See the difference between obstructive jaundice and surgical jaundice?
Sir, any correctable jaundice by surgery is surgical jaundice.
So give the examples of the obstructive jaundice.
Sir, obstructive jaundice is malignant obstructive jaundice is by the head of pancreas, periampullary malignancy, or hilar
That is a surgical jaundice, you know?
Yes, sir.
So surgical jaundice is a part of the obstructive jaundice.
Okay, sir.
But what are there other things obstructive which can cause the obstructive jaundice, but you cannot correct it by the surgical treatment. So give the example of that.
Sir,
Any medical jaundice can lead to obstructive jaundice? You know any medical jaundice leading to the obstructive jaundice?
Sir, cirrhosis, primary sclerosing, primary biliary cirrhosis.
Can a hepatitis lead to the obstructive jaundice?
Sir, in
hepatitis?
So in viral hepatitis, cholestatic phase can cause
Cholestatic phase, yes. Okay,
cause
cholestatic phase where you are not going to intervene. In the sclerosing cholangitis, you can still intervene. You know?
Okay,
But
sir.
in that, you are not going to enter. Okay.
Can I say something, sir?
Yeah,
Yes.
please.
So, sir's question, I will just add a little more and ask you one more medical conditions,
Okay,
which
sir.
are treatable by surgery. At the same time, they can also produce obstructive jaundice. Can you tell me that?
Which are treatable by surgery, and also produce medical jaundice.
Yes.
Sir,
Yes. Okay, I will give you a clue. What are the medical conditions which can give rise to gallstones?
sir, in case of sickle cell anemia, it can produce hemolytic anemia can produce
Very good.
pigmented
So
stones.
that is what also answer I wanted. They can also come to the CBD and give
Yes.
rise to obstructive jaundice. Okay.
Yes, sir.
Since we had discussed the first case also is obstructive jaundice, I will ask a little different question to you.
Okay,
In
sir.
your patient, gallbladder is palpable or not?
It's a palpable, sir.
Okay. Now tell me differential diagnosis for a palpable gallbladder. Forget about your case. Your case is there is a palpable gallbladder. Let us say, imagine 2 other situation or 3 other situation.
All possible differential diagnosis.
Yes.
Yes.
Sir, a carcinoma gallbladder, sir.
Yes. Where? Yes. Correct. Carcinoma gallbladder. Where? This is a favorite question of Dr. Ajay Khanna, sir. But yes,
sir.
go ahead.
So,
if there is a carcinoma in which part of the gallbladder, if it is present, then gallbladder may get palpably enlarged.
Sorry.
Yes. In the correct. In the
just think logic.
Which is a narrow portion. If it is blocked, there is yes.
Neck of the gallbladder.
Very good. So one is that is a possible. Now give me an example where there is no jaundice but gallbladder is palpable.
Benign condition.
Benign.
Sir, a mucocele of gallbladder.
Very good. So one is a mucocele of the gallbladder. Very good.
Yes.
Any other condition? If a mucocele gets infected, what do you call it as?
The empyema gallbladder.
That can be very tender gallbladder. Okay. Which group of patients are vulnerable for empyema?
Sir, diabetic patients.
These are the type of questions which will come in the examination. We want to assess you. You have a broad knowledge about these things, or you just see the ultrasound report, palpable gallbladder, and come. What about acute inflammation?
In acute inflammation.
When do you get appendicular mass? Similarly, can you get a gallbladder mass which is tender? Yes, try. Not difficult. Why you want to listen to your friend who is prompting you? I gave a clue, appendicular mass, any inflammation with or without a perforation, momentum, colon. So many things can come there and form a mass. Okay?
Okay, sir.
Hello?
A calculus.
Last but not the least, can you get a palpable gallbladder due to carcinoma itself? Not in the neck. Gallbladder itself.
Yes, sir.
What is the nature of that?
Sir, hard and.
So it can be very hard, very small gallbladder, maybe even with the lymph nodes at the porta or along the CBD, it can also give rise to obstructive jaundice. So you just keep it in mind, all these things. That's all from my side, sir. Please take over.
Can you get jaundice in a patient with a carcinoma gallbladder?
Sorry, yes, in case of if the extension into the liver.
No.
Liver extension will give you liver extension. You will get the jaundice because of extension of the liver.
Gallbladder carcinoma, what else can happen?
Sir,
what spread will be there?
The spread to the sir, the duct and the surrounding liver.
Lymphatic system? Can you think of that? Lymph nodal involvement?
The porta hepatis, the obstruction of the lymph node at the porta hepatis, large node causing obstruction at the porta hepatis can cause jaundice in say gallbladder.
Yes, so that is one reason. There are 5 or 6 reasons for that. So one is that there is a deposition in the porta hepatis is there. What are the other causes of jaundice in case of carcinoma gallbladder?
The tumor seedling into the duct can cause obstruction, and
there may be direct infiltration of the bile duct if it is from the neck of the gallbladder. Okay. Then a big mass, GB mass, can press directly over the CBD, causing the jaundice. If there are bilobar metastasis is there, then it can cause the jaundice. So can you tell if there is a single metastasis in the liver is there and that is causing the jaundice? Where will be that metastasis?
Sir, at the so
there's a metastasis in the caudate lobe is there.
Okay, sir.
Okay, the single metastasis in the caudate lobe can cause the jaundice. But otherwise, if it is a bilateral metastasis is there, then only it can cause the jaundice. But otherwise, 1 or 2 metastases will not cause the jaundice.
Okay, sir.
And then in about 10% cases, you have the associated gallstones in the CBD.
Okay, sir. And the stone.
Yeah, these are 6 causes of the jaundice in a patient with the carcinoma gallbladder.
Okay, sir.
So in a case of carcinoma gallbladder, do you get the stones or not?
Sir, it may, sir, a chronic cholecystitis can turn into a malignancy.
No, I'm asking you, in a case of carcinoma gallbladder, how common is the gallstones?
Sir, it has high risk for the carcinoma gallbladder transformation, the chronic cholecystitis.
I'm not asking you
Okay, sir.
risk and all those things. I'm just asking, you are given 100 specimens of
Okay, sir.
carcinoma gallbladder. In how many specimens you will get the gallstones? 5 or 10%, 20%, 40%, 50%, 80%, 100%.
Sir,
Choose in between that, yeah.
sir, 5%.
5%? No. It's about 70 to 80%.
Okay, sir.
Okay. So gallbladder stones may not be the cause for the carcinoma. It may be other way around also.
Okay, sir.
You know, the gallbladder stones are causing the carcinoma, then it should be a squamous cell carcinoma.
Okay.
But pathologically, the carcinoma gallbladder is the what type of the carcinoma?
So adenocarcinoma.
Yeah, they are mostly adenocarcinoma. So that theory is not very correct, that the gallstones alone are causing the carcinoma. It may cause, but it is not the sole cause for that.
Okay, sir.
Okay. So you want to keep any differential diagnosis here? You have just kept the periapulary carcinoma?
Sir, the ampullary region, the carcinoma at the ampullary region and the head of pancreas are initially I'm telling, sir, because there is no patient has not having any obstruction features. I am ruling out the duodenal part.
Now, what do you understand by periampullary carcinoma?
Sir, 2 centimeter around the ampullary region, it is either the distal bile duct or at the level of ampulla at the duodenal carcinoma and the head of pancreas.
So that will not cause the duodenal obstruction.
Yes, sir.
Okay, when you're saying the periampullary carcinoma, it will not cause the duodenal, it's only around the ampulla only.
Yes, sir.
And how do you differentiate clinically between a periampullary carcinoma and carcinoma head of pancreas? By clinical?
Patient will be having a progressive jaundice in case of a head of pancreas, sir. And there will be no history of melena and waxing and waning type of jaundice.
What is more prominent with the carcinoma head of pancreas? What symptom the patient will have more? Symptoms.
The increased the pruritus and a pain also may present.
Pain will be more compared to periampullary. Pain will be there. And jaundice will present later.
Painless progressive jaundice. Okay,
Yes,
it is initially the painless progressive jaundice, but later on the pain will come in that.
Pain will come, and the jaundice will come later. That is why patient present to you later, and the prognosis is not as good as in periampullary.
Yes.
Any other differential diagnosis you want to keep apart from the periampullary carcinoma?
So no, sir.
No, we were discussing about something just before.
So the head of pancreas malignancy.
No, that is any other one? We were asking about the causes of jaundice.
So
can it be a case of carcinoma of the gallbladder?
Sir, in that case, I cannot explain the melena and the waxing and waning type of jaundice. So,
what are the other causes of waxing waning jaundice?
Sir, in painful condition, choledocholitis and hemophilia, any worm infestation, choledochal cyst can under duodenal diverticulum can cause waxing and waning type of jaundice.
What is Klatskin tumor?
Sir, hilar cholangiocarcinoma is the Klatskin tumor.
Can you get the waxing waning jaundice in Klatskin tumor?
Sir, no, sir.
Will you have gallbladder palpable in Klatskin?
No, ma'am. In proximal obstruction, the gallbladder is not palpable.
If the patient is from the northern India, we always keep a possibility of it almost runs parallel.
Okay,
if we give a diagnosis of the pancreatic carcinoma, we always keep a possibility of the gallbladder carcinoma. Maybe in the south it is not there, but in the north we will always keep a possibility.
Okay, sir.
Keeping this provisional diagnosis, how you are going to work up with this patient?
Sir, I initially want to do a liver function test, complete blood count, and a prothrombin time of the and the electrolytes of the patient.
Okay, we have been repeatedly telling about that.
Yes,
and
sir.
Today, if you go to the scope which is there, that has been repeatedly told. Whenever you are suspecting a malignancy,
yes,
there
sir.
are 3 sets of investigation.
Yes, sir.
First set of investigation is
confirm the malignant,
make a diagnosis.
Yeah,
yes, to make a diagnosis.
Yes,
second set is to stage the disease.
yes,
and third set is the investigations for the treatment purpose. Okay, whether you're going for the chemotherapy or surgery or whatever you're doing.
Okay,
so always start with the investigations for the diagnosis purpose. So what is the first investigation you are going to do in this patient for the diagnostic purpose?
Sir, ultrasound of the abdomen
Okay. Now, when you're doing the ultrasound of the abdomen in this patient,
yes,
what
sir.
findings you are going to get?
Sir,
Well, in order, what are the various things you are going to see?
Sir, I want to see the site of obstruction and also the level of the lesion, the site of obstruction, either it is a proximal or distal. How is the common biliary duct, pancreatic duct, and intrahepatic biliary radical? How is the gallbladder? And look for the free fluid and look for the liver, either it is metastasis or not. And possible lymph nodes can be assessed, and the vein, the portal vein and superior mesenteric vein, any thrombosis can also be assessed.
What you will see in the liver in this patient? in this patient?
Sir, the liver is the liver has a clinical hepatomegaly, and I want to do any lesions present over the liver. It's a smooth.
What lesions you will see
the
in the liver?
metastasis.
Metastasis you may see, okay. But what is the commonest finding in a patient with obstructive jaundice in the liver?
So congestive.
By which you can differentiate whether you are dealing with a case of medical jaundice or a surgical jaundice. What is the finding in the liver to suggest that?
The presence of size and the cirrhosis, the surface.
Intrahepatic.
So the intrahepatic biliary radicals.
That is the most important.
Yes, sir.
That will differentiate, are you dealing with a case of medical jaundice or a surgical jaundice?
Yes,
right. So there will be hepatomegaly will be there, the liver will enlarge, and you will find the intrahepatic biliary ductal dilatation. Now then you come down to the bile duct. What you will find in the bile duct?
Sir, the common bile duct, how is it is dilated and
what is the normal diameter of the bile duct, common bile duct?
So 6 to 8 mm.
So you have come down to the bile duct where you see it is dilated. Then you go to the gallbladder. What do you see in the gallbladder?
Sir, I want to see whether it is distended and any calculus is present.
Then you go to the pancreas. What do you see in the pancreas?
So I want to see the diameter of the pancreatic duct and any problems.
What is the normal diameter of pancreatic duct?
Sir, 3 in the head, 2 in the body, and 1 mm in the tail.
So here we are interested in the head of the, because we are suspecting lesion in the head of the pancreas.
Yes, sir.
So if it is more than 3 millimeters, so if the bile duct is dilated and also the pancreatic duct is dilated, this is called as?
So double duct sign, and which is suggestive of head of pancreas malignancy.
Right. Okay. Then you see for the lymph nodes, you see for the ascites.
Ascites.
These are things you are going to see in the
ultrasound of the.
You know, when you're doing the abdominal ultrasound, what is the frequency of the probe which is used? Any idea?
So 10 to 12. So in abdomen, this is 3.5 to 5 hertz is used, sir. And
3.5 to 5 what?
Hertz, megahertz.
Megahertz.
Yes.
3.5 to 5 megahertz. If
Yes,
you are
sir.
doing a TVS or the truss, then what is the frequency?
Then 12 megahertz.
It is 7.5.
7.5. Okay, sir.
If you are doing a breast and thyroid ultrasound, what is the frequency?
Sir, 10 to 12.
10 to 12. If you are doing endosonography, endo ultrasound, what is the frequency?
Sir, 15 to 17
megahertz. And if you are doing intra-op ultrasound, what is the frequency?
20.
Always the same, too, around 15. No?
Okay.
Around 15 megahertz. Okay. So you have done the ultrasound in this patient. You find there is a double duct sign is present.
Sir.
There is no ascites.
Okay,
There are
sir.
no metastases to the liver.
Okay, sir.
Next, what you are going to do?
Sir, I wanted to do CCT abdomen pancreatic protocol to stage the tumor.
So if you are doing a CT scan, how do you read the CT scan?
How to read this?
What should be a sequence of the reading the CT scan?
So from so without contrast, pre-contrast.
No, CT scan.
Okay, sir.
Contrast enhanced CT scan has been done.
Yes, sir.
You have to follow a sequence. What it's the same as a TNM. Okay. You follow the same sequence like the TNM. So you have to look, see for the tumor, you have to see for the nodes, and you have to see for the metastasis.
Okay, sir. Sir, in 20 seconds, and we have to in arterial phase, parenchymal phase, and
I'm not talking the pancreatic protocol as such.
Okay,
Any
sir.
CT scan for any malignant tumor suspected, this should be the sequence of study of that. So first you have to see about the tumor which is there. And then you have to see that where is the tumor, how big is the tumor, what is the surrounding invasion of that tumor. Okay, so that will tell you the T status. N for the lymph nodes and M for the metastasis. Any liver metastasis is there or not, any peritoneal metastasis which is there. So that should be the sequence of that. So what are you interested in this patient? If the patient has a carcinoma head of the pancreas, in the T status here.
So what is the size of the tumor I wanted to ask? And first the size of the tumor and the size of the tumor I have to assess.
After that size, if the 4 centimeter tumor is there.
Yes, sir.
What next you want to know?
Sir, I wanted to know the involvement of the vessels, that is the portal vein, superior mesenteric vein, and the superior mesenteric artery.
So out of these 3 vessels,
yes, sir.
Which will say that you cannot go for a radical surgery?
So,
portal vein, superior mesenteric vein, and the superior mesenteric artery.
So, in superior mesenteric vein, if there is an abutment, there is a borderline resectability, and that is encasement, we can unresect it. Superior mesenteric artery.
Artery is the most important culprit, and you can do the section of the vein and the reconstruction of that, but the artery cannot be done.
Yes, sir.
So you have done the CT scan of this patient.
Yes,
you
sir.
find there is a 2.5 centimeter lesion in the head of the pancreas.
Yes,
and
sir.
There is no fixity to the surrounding areas. There are no nodes are there, and there is no metastasis is there. What next?
Sir, also I wanted to next I wanted to do the blood investigations for the patient.
Are you happy with the diagnosis? You are finished with the diagnosis?
So then I wanted to do an endoscopy. I wanted to take a endoscopy guided biopsy of the lesion, sir.
Can you tell what are the various ways to take the pancreatic cytology or the biopsy? What are the various ways?
Sir, through the the brushing cytology, the bile can be sent for the cytology, and a biopsy can be taken with through the endoscope. And
what is it called? It's pancreatic malignancy biopsy is mandatory.
Ma'am, in case we are going for a palliation or a neoadjuvant, we have to take a biopsy. Otherwise, it is not mandatory to take it.
For the surgical treatment, it is not mandatory.
Yes.
But if you are planning for the chemotherapy, yes, it has to be there. Okay.
Sir, can I ask a question?
Yeah, please.
Dr. Janani, we have checked for all resectability of the tumor and vessels and all.
Yes,
what
sir.
else will you like to know personally if you are an operating surgeon before putting a knife on this patient?
Sir, peritoneal metastasis cannot be assessed.
All patient is absolutely resectable, curable as far as the radiologist report is concerned. What anything do you like to know any more information before going in? You are the chief operating surgeon. Technically, very, very, very good disease. By your experience, it is curable surgically. What else extra information will you like to know? Radiologist has reported everything: vein, artery, no abutment, it is free from this, no nodes, no free fluid, no peritoneal metastasis. You have checked everything, but will you like to know anything more from radiologist?
Sir,
You get my point, so that you don't create a problem intraoperative. Vascular anatomy.
yes, sir. Okay, sir.
Abnormalities of vessels. From where do you expect?
Sir, the inferior pancreatic or duodenal.
No. The superior mesenteric can be giving branch to hepatic artery, right? There can be left gastric artery can be gastric artery can be giving to left hepatic artery. All these anomalous vessels you have to keep in mind, and you have to ask radiologists to look for all these major vessels where they are branching, whether they are abnormal or not. Okay, so that if at all they are there, you can take care of them while dissecting.
Okay, sir.
Aberrant.
Aberrant vessels, yes. Aberrant, yes.
Okay, then you have made a diagnosis now in this patient.
Yes, sir.
So the second step is now, what is the second step?
Sir, I diagnosed and staged the tumor. And
so for the staging purpose, what you are going to do?
Sir, I wanted to do a CA99 and PET scan if patient is affordable, so that the metastasis can be assessed. In addition to
is PET scan a good investigation in the pre-operative setup? Because there are many false positives are there which can come. Sir. If somebody has got any infection anywhere, any inflammation is there, or somebody has broken his bone metastasis, that will give us a positive part there. Okay. So it is not good for the. So that is why in the AGCC, in none of the things it has come as a diagnostic modality, except like in the unknown secondaries which are there in the neck, you can do the PET scan, but otherwise not even the breast carcinoma or any other carcinoma. It is not in the pre-operative setting. It is only after that you can, once you have given the treatment, you can follow up your patient with the PET scan. Okay. Then?
Sir, then I want to...
this patient is a good candidate for carrying out the pancreatic duodenectomy.
Okay, sir.
Right. So now you have to do the third set of investigations.
Sir, I wanted to do...
So what are you going to do?
Sir, a complete blood count, liver function test, renal function test, prothrombin time, the chest X-ray.
LFT says his bilirubin is 25 mg%.
Direct bilirubin. Okay.
Total bilirubin is 25.
Okay, sir.
What risk is there for anesthesia?
Sir, ma'am, they cannot give halothane since it causes halothane hepatitis. They have to avoid all the medication causing anesthesia medication.
Or can you bring down the jaundice?
Ma'am, yes, if since we can bring down the jaundice by any biliary drainage preoperatively, if in case the patient is having we are postponing the surgery, or we are giving a neoadjuvant, planning to take a neoadjuvant, or in case of severe pruritus and the patient is having cholangitis, then we can plan for a biliary drainage.
Is it always a must to carry out the biliary drainage?
So no, sir.
No, when you want to operate, no need.
Yes, sir.
But I gave you the choice. The patient bilirubin is 25 mg%.
Okay, sir.
And as a surgeon, I want that his bilirubin should come down. So what can you do?
Sir, before proceeding to the surgery,
yes.
Sir, in case of lower distal obstruction, we have to do an endoscopic biliary drainage. So by placing a
is
stent.
ERCP better or doing the PTBD is better?
So PTBD is better in case of an proximal obstruction, sir, and endoscopic biliary drainage is better in case of a distal obstruction.
Okay, it has been seen that if you are doing the ERCP drainage for these patients, even if it is a lower obstruction is there,
Yes, sir.
the technical surgical resection becomes very difficult.
Okay, sir.
Because the inflammation introduced by the stent which is there.
ERCP.
So technically it becomes very difficult. And that is why there are few studies which have come that they say that for the short term, if you want to do the PTBD rather than going for the ERCP drainage here.
Okay, sir.
Okay. So in the PTBD, that problem will not be there.
Okay, sir.
Okay. What are the other ways to prepare this patient apart from the bilirubin? What are the other things you are going to do for pre-operative preparation?
Sir, I will, in obstructive jaundice, the patient will be having prolonged prothrombin time. I wanted to give vitamin K for 3 days. IV injection.
Vitamin K you are giving and how much you are giving?
Sir, vitamin K, phytomenadione, vitamin K1, we have to give. IV.
How much? How much?
Sir, 100
10 milligram per day for 3 days. No?
Okay.
Also, by giving this vitamin K, will his INR will come to normal?
Sir, if he's not having liver cell failure, it will come to normal. If it is not coming down, we have to transfuse fresh flow some plasma.
It will never come to normal.
Okay, sir.
Okay. Whatever you do, it will never come to normal.
Okay, sir.
Okay, it will stabilize or become less, but never normal.
Okay.
Okay. Then
What else you will correct?
I want to check his hemoglobin and optimize his hemoglobin level, and the albumin I have to check so that the anastomosis will be healthy, and
Proteins, total proteins and
proteins
ratio.
will you give the patient antibiotics?
Sir, since patient is having obstructive jaundice, I would start on third generation cephalosporins.
Will you give the patient thromboprophylaxis?
Yes, sir. Patient pre-operatively 12 hours prior to the surgery, I will give a low molecular weight heparin.
What about the glucose? Do you want
Sir,
to
high glucose
storage of the liver?
Sir, high since sir, for the glycogen storage will be depleted in the obstructive jaundice, so I want to give high carbohydrate diet for the patient.
What is the place of diuresis?
Sir?
What is the place of diuresis? Will you like to give the patient mannitol? To prevent the hepatorenal shutdown?
Yes.
Usually not done, but you can give the mannitol if there's a very high bilirubin is there.
Okay, sir.
Okay, so you have prepared your patient. You are taking up this patient for the surgery now.
Yes, sir.
Patient is on the operation table. How will you proceed?
Sir, I would like to start with the diagnostic laparoscopy and then proceed with the...
Why you want to do, everything is clear.
Yes, sir.
But still you want to do a diagnostic laparoscopy? You're right, you will do it, but for what purpose?
Sir, since peritoneal metastasis cannot be assessed by the CT scan, so I wanted to do a diagnostic laparoscopy and proceed.
So for the peritoneal metastasis mainly.
Yes, sir.
So that is clear.
So then I will proceed with the pancreatic duodenectomy.
What incision you are going to make?
Sir, if the patient is obese, I will do a rooftop chevron incision. Otherwise, midline laparotomy incision would be better.
You entered inside the abdomen.
Yes, sir.
What is the next step?
So first is the Carrot maneuver, where I want to release the lateral peritoneal wall attachment to the colon and bring down the right colon down to visualize the duodenum and the SMA. So then I wanted to do an extended Corchus maneuver. Then
up to what level you will do the extended Cockers maneuver?
Sir, renal vein, left renal vein.
Left renal vein. Okay.
Yes, sir.
Then
I wanted to between the pancreas and the superior mesenteric vein, I have to see the plane is free, the fat planes are free, so that I want to assess the fat planes between the pancreas and the SMB and portal vein. And if it is normal and fat planes are maintained, then I
Will you
want
reach portal vein?
Sir,
So it is not written there, no? So how can you reach portal vein? And then you can proceed further behind the neck of pancreas.
Sir,
Is there any landmark?
inferior pancreatic or duodenal artery.
These are small vessels. They'll come later on. You follow middle colic vein.
Middle colic vein. Okay.
Right. Which tributary will you like to take care when you follow middle colic vein? Right, gastroepiploic.
Okay, sir. So then wanted to proceed with if this resectable, then I wanted to proceed with the resection part. First, we have to start in the
How do you know that it is resectable?
Sir, if the posterior, the pancreas and the love of tunnel, the tunnel of love is palpated and
No, before that, you will go to the tunnel
yes,
after you have confirmed that it is resectable.
Yes.
Not before that. So how do you ensure that you are dealing with the resectable? You said in one of your answers that you will not resect a pancreatic malignancy if there is which vessel involvement?
Sir, superior mesenteric artery.
Yes.
Yes,
so when you do the extended cauterization,
yes,
you have to expose the root of the superior mesenteric artery,
artery. Okay.
right? And you have to define the retroperitoneal margin, whether there is more than 180-degree encasement of that vessel. If that is there, it is not resectable. So it's a superior mesenteric artery approach, right?
Yes.
Once you understand that it is resectable, then only you try the other things, which you're saying, the steps, right? Right. So when you are defining the portal vein,
yes, sir.
There is an important vein which Dr. Andheriya was saying, which you should be very careful of. Are you aware of that? Is there a trunk? It's known as the trunk of Henle. Have you read it? Okay, no problem.
No problem.
Now, about the artery, so which artery, while you are defining, you know, you have gone for resection.
Yes,
These two things, one is a vein, the trunk of Henle. The second
Yes,
one is the artery. That
Yes,
artery you have to be very careful of, and you have to know whether that artery is important because it supplies it gives blood supply to the common bile duct, the trunk. What is that?
So the right hepatic part.
No,
Hepatic.
it is a gastroduodenal, GDA. Gastroduodenal artery. Because in certain cases, the celiac artery or celiac trunk can have stenosis.
Yes,
Age-related, there can be calcifications, stenosis is there.
Okay,
and that is
sir.
the time when the gastroduodenal artery supplies blood from the
Okay, sir.
superior mesenteric artery backflow to the hepatic artery. So if you have not confirmed the gastroduodenal, if you have temporarily clamped the gastroduodenal, soft clamping, will supply the hepatic supply is maintained. That means you can go ahead with ligating the gastroduodenal. Otherwise, there'll be patient will die in the postoperative period. There'll be immediate liver failure because hepatic artery will be ineffective, right? So these two, one is this vein, and the rest of the all small veins which directly feed the pancreatic parenchyma from the the portal vein, that you have to ligate, otherwise they'll bleed a lot, right? These two important vessels you have to keep in mind, right? Where will you resect the common bile duct or the extrahepatic bile duct?
Sir,
above the cystic duct or below the cystic duct?
So above the cystic duct.
Why?
Sir, you're going to do a cholecystectomy or as well.
Yeah, why you want to do a cholecystectomy? There's no problem with the gallbladder.
Yes, sir.
Yeah, then why you want to do it?
So we are going to do an hepatic cholecystectomy.
Yeah, that's okay. But my question is, why you want to do it? So two reasons. One, you have to resect the hepatic duct high.
Yes,
because the blood supply comes from above. So if you have a big hepatic duct stump, the chances of anastomotic failure is there, biliary enteric anastomosis. Okay. The second is that you're taking out the duodenum, right?
Yes, sir.
So how does the enzymes, the hormones which contract the gallbladder for emptying comes from the duodenum?
Yes, sir. Yes, sir.
So there will be biliary stasis, stone formation, right?
Sir.
So the gallbladder itself will be a major problem in the postoperative period.
Yes.
Okay, so the first reason is that your blood supply comes from above. So you have to resect it 2 centimeters beyond the confluence to give a successful biliary enteric anastomosis, not which can leak, right?
Yes, sir.
And one more thing, sir, I like to add that you take
Yes,
out the lymph node sitting on hepatic artery, and from there you begin coming down to bear off all CPD, portal vein, hepatic artery to do a lymphatic dissection.
Right.
Okay.
Very well done.
Very well done.
Very well done.
But if your questions are going up to pancreatic or duodenectomy, you must understand you have got very good marks.
Yes.
Okay.
Thank you,
excellent.
Sir.
Fantastic.
Thank you, sir.
So what are the structure you are going to remove?
Sir, the duodenum, the head and the neck of the head and the uncinate process of the pancreas. In case of the distal stomach and up to the gallbladder and up to the cystic duct, I have to remove.
How much stomach?
Sir, 40% of 40 to 50% of the distal stomach.
That was the classical Whipple's operation which was there. But now nobody does that distal gastrectomy also.
Sir, pylorus preserving surgery.
Even if it is not a pylorus preserving,
yes, sir.
you just remain toward near the pylorus only.
Okay, sir.
So you are not going to dissect so much of the stomach.
Okay, sir.
When will you not do a pyloric preserving surgery?
Sir, if it is involving the first and the second part of the duodenum,
you're not able to keep the first part of duodenum 2 centimeter or 2.5 centimeter of duodenal stump, right?
Yes,
for an anastomosis.
Anastomosis.
Yeah. Then you go for you can go for the distal gastrectomy. Yeah. Distal gastrectomy.
And how much jejunum?
Sir, 15 to 20 centimeter from the DJ flexure, we have to start dissection from the jejunum.
And why is that?
So to mobilize the jejunum.
No. It has to do with vessel. Blood vessel. So the first branch of the first branch
of the jejunum comes from
jejunal
the
branch of the superior mesenteric artery.
Yes, sir.
Right? That supply starts at least 10 centimeter from the DJ. At least 10 centimeter. The variation is there, right?
Yes,
so never dissect within 10 centimeter of the DJ. That part is supplied by the pancreaticoduodenal vessels.
Okay, sir.
Okay. Yes. So you'll end up with a avascular enteric margin.
Okay, sir.
So safe margin, as you said correctly, 15-20 centimeter
Yes,
of
sir.
jejunum stump.
Yes, sir.
What other procedure is essential after a pancreatic duodenectomy before closing the abdomen?
Feeding jejunostomy, we have to use.
So that
enteral feed can be started earlier.
With an enteral feed.
Yes.
Post-operative complications?
Initial.
Be brief and important complications. Dr. Kanagavel sir wants us to close at 10:30.
Okay,
Madam?
We'll close, sir. No problem.
Yes, madam. Yes, madam. I'm just waiting for you to finish.
Yeah.
Dr. Kanagal,
Yes, sir.
Is the virus transmitting through the internet?
Which one, sir?
The virus.
I don't think so, sir. Why, sir?
You're on mask. That's why I'm asking.
No, sir. No. I'm still in the hospital, sir. I'm still in the hospital.
Okay.
We still have corona cases in our hospital, sir. We have 9 patients as of now.
Okay.
We don't admit, but a patient requiring oxygen are still coming up, sir. It is not totally become zero.
He religiously comes on Fridays at 8 p.m. irrespective of where he is. Hats off, sir. Hats off.
Yeah.
No, sir,
Really hats off to Kanagavel sir.
We get to have calls and we operate on corona patients also. So it is difficult to wear specific masks and non-specific masks. So we wear all the time. Still, all of us wear N95 all around, sir.
Yes, universal precaution.
Yes, sir. Yes, sir. Thank you, sir. Thank you for joining us. I thank Harsh Dayade and Janani for making this evening a lively one. Kanna sir, Jailal sir, Som Prakash sir, and Hitesh sir. I think few of them have already left. Thank you very much for joining. Som Prakash sir, if somebody, one of your PGs can present in the coming weeks, you please kindly contribute, sir, if it is possible.
Okay. Yeah,
Not
I'll let you know.
The subsequent week also is fine, sir. No problem. Sir.
I'll let you know.
Thank you very much, sir. Sharda ma'am, thank you very much. Kanna
Thank
sir,
you. Thank you, sir.
Good night, sir. Janani and Hitesh.
Thank you, sir.
Hitesh sir, good
Thank you so much, sir.